Das, Assistant Professor of the Royal School of Medical and Allied Sciences, and I shall be the moderator of session of the RGO departmental webinar series entitled Thoracic Outlet Syndrome and its Hidden Aspects. In the beginning, I would like to welcome our esteemed panelists and all the participants of the session. Located against the picturesque backdrop of the Tirupati Balaji Temple on National Highway 37, the Assam Royal Global University stands high with its virtues of excellence and a humble contribution to the society at large. The campus is built over 27 acres of land and is running various courses under 27 different schools for UG, PG, and PhD students. In the beginning, I would like to request all the participants to mute their audio and turn off their video for a smooth operation of the webinar. COVID-19 has made us to stay at home, which has led to work from home culture. People are sitting in front of computers and other gadgets for a longer period of time. This has led to alteration of the biomechanics of the body, and as a result, a number of back and neck issues have arisen. Today, I would like to request our esteemed speaker, Dr. Arunmozhi sir, to educate us about one of such conditions known as the thoracic outlet syndrome, which is a burning condition of the modern day world. Dr. Arunmozhi sir is working as an associate professor in the Department of Physiotherapy, Sardar Bhagwan Singh University, Dehradun. Sir has more than 15 years of experience in teaching and training the future physiotherapists of the nation. Sir holds numerous degrees under his name, most prominent among which are Bachelor's in Physiotherapy from Puducherry University, Master's in Physiotherapy from Devi Ahilya University, Indore, Foundation course in myofascial release from UK, diplomas in celiac manipulative techniques and force massage from United Kingdom, and a diploma in yoga medicine from the British School of Yoga, United Kingdom, along with a PhD in physiotherapy. He is a pioneer in the field of physiotherapy, having worked in Dhaka, Colombo, and different states of India. He was awarded with numerous awards, prominent among which is at the World Confederation of Manual Therapy in 2007 for his research work, physiotherapy treatments in suboccipital muscle, trigger points, and headache. Sir has taken workshops on myofascial release in conjunction with other soft tissue techniques, passing his experience to talented physiotherapists and the young students from all over the world. We welcome you, sir, and look forward to hear from you. The mic is all yours, sir.
Thank you. Thank you so much, Abhishek. Thank you for welcoming me for this webinar. Because of Dr. Abhishek Das only, I am here in front of you because he was one of my old student and very regular and very sensitive student also. So thank you for this opportunity, Abhishek.
Pleasure is all mine, sir.
To present a seminar, that is webinar in thoracic outlet syndrome for your students. And I think I prepared something for you. If you understand well, then it's okay. If you are not understanding, you can ask questions in the question and answer box. So I try to give some answers. Okay. Without wasting your time, we go to the presentations. First, I share the screen. Yes. So this is today's topic, thoracic outlet syndrome, and its hidden aspects. First of all, why I chosen this topic? Because most of the physiotherapists, we doesn't know how to differentially diagnose the condition. Not all the physiotherapists, some of the physiotherapists, they are really good with their differential diagnosis, and some of the other doctors or medicine people, you have any the general physicians, they are have some problem with the differential diagnosis. Here also I prepared some of the differential diagnosis that I present in front of you. And with this, I'm sure that you have some clear idea about how to rule out the particular thoracic outlet syndrome or the pseudo thoracic outlet syndrome. It is not moving. 1 minute. I am not getting this. 1 minute. Yeah, time back. So this is the actual definition of thoracic outlet syndrome. But according to the book I given this definition, it is a collection of symptoms we see in this, and there is a compression of brachial plexus and subclavian artery by attached muscles in the region of the first rib and the clavicle. Apart from this, we have some of the other area of compression also. So according to the area of compression, we have some different names. If it is compressing at the scalene area, that is in the scalene tubercle, scalene triangle. So we have the scalenus anterior syndrome. One. The second one is we have a problem in the pectoral area, that is pectoralis minor area, pectoralis minor pain, that we say pectoralis minor syndrome. Another area is the space between the clavicle and the first rib, that is we say costoclavicular area. So according to the area of compression, we have different names of this condition. And the types of thoracic outlet syndrome, it is of three types. One is the neurogenic, venous, and arterial thoracic outlet syndrome. Neurogenic thoracic outlet syndrome, arterial thoracic outlet syndrome, and venous outlet thoracic outlet syndrome. So what happened here? So according to the compressing structure, we say the name of neurogenic, venous, or arterial. According to the compressing structure, these are the compressed structures. Compressing structures are the muscles, we can say, or bone, we can say, or any other tendon which is compressing. So according to that also we give some other names. That only we are going to see. So first of all, the neurogenic thoracic outlet syndrome. In this, any abnormalities of bony or soft tissue in the lower neck region, that is C6, C7 area, that compress and irritate the nerves of the brachial plexus, particularly the brachial plexus, we say neurogenic because it is compressing the nerve and its surrounding structures or its coverings. We say neurogenic thoracic outlet syndrome. And the symptoms includes weakness or numbness of the hand, decreased size of hand muscles, which usually occurs on one side of the body, and tingling, prickling, and numbness and weakness of the neck, chest, and arms. So these areas they have that tingling and prickling sensations. So we can say that this is a neurogenic thoracic outlet syndrome. You can say that some bony outgrowth which is compressing the nerve and its tissues. And the second one is venous thoracic outlet syndrome. So any structures which damage the major veins in the lower neck and upper chest area. This also develops suddenly. It won't develop gradually. It develops suddenly, often after unusual and tiring exercise of the arms. So sometimes people who's doing some exercises in the upper part of the shoulder, so they have this kind of venous thoracic outlet syndrome. So what are all the symptoms we will see in this venous thoracic outlet syndrome? First of all, the swelling of the hands, fingers, and arms, as well as a heaviness and weakness of the neck and the arms. So in the arms also they have the heaviness. Along with that, there is a visible swelling in the arms and fingers, and they have the anterior chest wall veins dilated. So you will see something it is dilated here. Most of the people they will complain, and particularly who's having a facial joint arthropathy. So they have a swollen neck here between the scapula and the clavicle. So in that condition, you can treat that. So venous thoracic outlet syndrome. The third one is arterial thoracic outlet syndrome. This is a very rare condition. The artery which go and compress between the bony structures, and mostly it is congenital. Means from birth it will occur, so it won't occur gradually. It is at the birth itself some anomaly will compress the artery, and if the patient is having a compression in the arterial area, they have cold sensitivity in the hands. They won't say any numbness. They won't say any swelling also in this, but cold sensitive. Always they say cold sensitivity in the fingertips or in the thumb. Okay. Numbness, pain are source of the fingers, and poor blood circulation to the arms, hands, and fingers. If you press this area, there is a blanching of blood will be there. So this won't occur suddenly. And this will the fill up will go very late. By that way, we come to know that. So according to the compressive structures, the scalene muscle is one of the major culprit here. If the patient is having a scalene inflammation, they have a compression in the uh, brachial plexus, that is between the anterior and middle scalene muscles. They have the neurovascular bundle. So particularly the brachial plexus, which is going to compressed by scalene muscles. That's why we call it as Scalenus anterior syndrome. So mostly the anterior Scalenus anterior muscle, which is compressed. So the origin and insertion I given the diagram. I no need to explain. I think it is starting from the third cervical vertebra transverse process anteriorly up to the sixth cervical vertebra, third to sixth. That is four vegetation, and which come and attach at the first rib area, the superior aspect of the first rib. So according to the scalene muscles, all we know that three scalene muscles are there: anterior, middle, and posterior. But also we have a minimus muscle. So that only we are going to see minimus, how it is going to give pain. First of all, we see the posterior. The scalenus posterior muscle. So this is the lowest two or three cervical vertebra origination, and which inserted on the lateral surface of the second rib, and sometimes it will go to the third rib also. The scalenus posterior crosses the first rib posterior to the scalenus medius and deep to the anterior borders of the upper trapezius and the levator scapularis. So this area compression, which is very rare, but if the patient is having pain or any trigger points in the scalenus posterior area, they have pain over the neck area and the superior aspect of the anterior superior area of the chest. Okay, next one is the Scalenus Minimus. The origin extends above to the anterior tubercle on the transverse process of vertebra C7 and C6 sometimes, and this is going to attach with the fascia supporting the pleural dome and beyond to the inner border of the first. If we see that the clavicle, okay, if you want to palpate the apex of the lung, so we keep this much gap above the clavicle. In this area we say that tubula area, the dome which is called the cupola. Okay. cupola, C-U-P-O-L-E. Okay, cupola. So that is a fascial area which is attached. So whenever patient is having pain or tenderness in the Scalenus Minimus, it is going to pull that fascia. They have paradoxical breathing. So according to that, this muscle is one of the important muscle for breathing. So this is the muscle. So this is attached at the dome, that the superior aspect of the lung, and which is arise from C6 or C7, mostly C7 area, or sometimes in the C6 area. If the patient is having pain in the scalenus anterior or posterior or middle, they have a radiating pain in this dorsal area. Okay, this dorsal area. So this is for the C6 area. C6. This is C6 area. Okay. So C6 and nerve root compressions. The patient is having pain in the Scalenus minimus. They have pain in this area over this down the bulk of the deltoid. Down the bulk of the deltoid. Sometimes they have chest pain also. Scalenus posterior, so we already seen this. Here the left side diagram which is showing that how to release the Scalenus posterior with the muscle energy technique. This is the position from the muscle energy technique of Scalenus posterior. We are going to rotate the head fully and extend the neck. We are going to rotate the neck fully and extend the neck. After that, therapist apply a resistance here and ask the patient to do a rotation towards the same side. The therapist should apply resistance and make the patient not letting do a resistance, that is resisted rotations. So maintain this pressure or isometric contraction for 7 seconds. 7 seconds only you have to hold that resistance. After that you leave it like that. If time permits, I will show you the video, the live demo. Scalenus medius, it is arising from the C2 through C7 area, and this is the broadest muscle because of the fibers is from C2 to C7. I inserted the cranial surface of the first rib, posterior and part of it deep to the groove for the subclavian artery, and sometimes a slip of the muscle sometimes extends to the second rib. So Scalenus medius, we should not expect that insertion will go only to the first rib. It may go to the second rib also. So this is for the muscle energy technique to the Scalenus middle fibers. For the Scalenus middle fibers, we rotate the head to 45-degree towards opposite side. After that, you apply the resistance and maintain this resistance in this position for 7 seconds, and after that leave it, and your neck should be extended always during this technique. Scalenus anterior, yes, this also we already seen this. It is arising from C3 to C6 area, and the Scalenus anterior is this way. It is in the neutral position. And ask the patient to try to do a rotation towards the same side. If the patient is having pain in the right side, ask the patient to rotate on the same side and maintain this isometric contraction for 7 seconds only. 7 seconds or 7 counts. So the next muscle which is going to give this thoracic outlet syndrome is the pectoralis minor muscle. So why it is so? Because under the pectoralis minor tendon, where it inserted at the coracoid process of the scapula, so there it get irritated when the pectoralis minor go into contraction. This tightened muscle which is going to compress that area. So again, the patient will get pain. So here in the diagram, the right side diagram, the clavicle has been removed here. Here, see this, the brachial plexus and the subclavian artery. So again, the patient have pain in this area. So the whole area, this whole area, and the outer side of the forearm and the hand here. Of the patient have, most of the patient have pain over this area. Sometimes they have pain in the other areas. This is a diminished pain radiations in this area, or patient have pain here and it is concentrated in and around the coracoid process and the chest where it is attached. From the three digitations, it is starting from the second, third, fourth, and the fifth ribs and attached at the tip of the coracoid process. So this diagram also it has been shown like how the brachial plexus which is going and the artery and the vein, the subclavian artery and the subclavian vein which is going under the pectoralis minor. So this diagram clearly explains you that if the patient is having a tight pectoralis minor, it is going to compress this neurovascular bundle. So this condition has been called as pectoralis syndrome. That is pectoralis minor syndrome. Pectoralis minor syndrome. So this is the testing how to do whether the patient is having that problem due to pectoralis minor or not. Overhead abduction we have to do. Along with this, the therapist should palpate the radial pulse and ask the patient to hold this position. Okay, so usually what happens, the neurovascular bundle which won't compress in the pectoralis space, but in the tight pectoralis minor, the patient have a diminished pulse. So with that, we come to know that the patient is having some tightness in the pectoral muscles. Right? So you have to release the pectoralis minor muscle particularly. So the third area where it is going to compress is the costoclavicular space. So this is the costoclavicular space. So you see here the first rib and the clavicle. And from the first rib, the subclavius muscle also which is coming up and attached with the clavicle. And from the subclavius to the scalenus anterior muscle, we have a subclavian vein. If the patient is having costoclavicular syndrome, they mostly have the venous problem. They mostly have a venous problem, or if the patient is having subclavius muscle tightness, then also they have a pain over that area. If the patient is complaining about swelling in the hands, then you have to release the middle area, medial area to the middle of clavicle. Under the clavicle you have to release in order to release the subclavius muscle. In order to release the subclavius muscle, we release under the clavicle from the sternal end to the middle of the clavicle. Costoclavicular space. We say in myofascial release technique, upper thoracic release. Upper thoracic release. So this diagrams which is showing all the three area of affection only. So the first one, this is for the Scalenus triangle, Scalenus antigus syndrome. The second one is costoclavicular area, this costoclavicular syndrome. And the third one here it is the coracoid process, and the coracoid process and the pectoralis minor. So this is this area is the pectoralis minor space. So all this area. So this is the three spaces. According to the spaces, we name the syndromes: Scalenus antigus syndrome and the costoclavicular syndrome and the pectoralis minor syndrome. So the another two diagrams which is showing that is they maximize the area, the scalenus anterior muscle, scalenus middle muscles, between the two muscles, how the brachial plexus which is coming. The white color one is the brachial plexus. So whenever this muscle tightened or inflamed, this is going to compress these structures. Subclavian artery, it may compress or it may compress a brachial plexus. So here the down, the C diagram which is showing it, this is a costoclavicular space. Here you see the subclavius muscle, anterior scalene. In between this, we have the subclavian vein and the scalene anterior and the another muscle, scalene middle. In between these two, we have the brachial plexus and the subclavian artery. So here also, so according to the symptoms, we know that in which area the compression is there, whether the problem which is coming with the subclavius muscle or the problem is coming with the scalenus anterior or middle. So easily you can diagnose it. So according to this, we say that whether the problem which is neurological TOS, that is thoracic outlet syndrome, or venous or the arterial thoracic outlet syndrome. Apart from these three muscles, we have some of the other muscle also. And in the myofascial pathology, we say the pseudo-thoracic outlet syndrome. Pseudo-thoracic outlet syndrome. So mostly the trigger points in the muscles, all these four muscles, this also mimic the symptoms of thoracic outlet syndrome. So the four muscles, the extra four muscles are pectoralis major, latissimus dorsi, teres major, subscapularis. So how these muscles which is going to give pain, according to the referred pain, we say that this is pectoralis major, latissimus dorsi, teres major and subscapularis. Pectoralis major, we already know that it is having three fibers. So one is the clavicular fiber, sternal fiber and the costal fiber. And also we have some of the abdominal fibers. So the costal fiber extends to the abdominal cavity. So those muscle fibers, we say the abdominal fibers. So in the diagram, which is clearly explained that the patient is having a clavicular head muscle fiber trigger point or tender spot. They have pain in the anterior aspect of the shoulder, only the anterior aspect of the shoulder. If the patient is having pain on the middle fiber, that is sternal fiber, upper sternal we say, if they have pain, then that pain will come and continue throughout the arm. Particularly if the suppose a patient is having pain in the medial epicondyle, like a golfer's elbow complaints if they are telling, then you automatically first search the tender spot over the middle fiber of pectoralis major and the lower fiber of the pectoralis major. The patient complains pain around the nipple area, around the breast area. So you can easily find it out according to the referred pain where the tender spot is. So here the point of consideration is how it is mimicking the thoracic outlet syndrome. So particularly the pectoralis major middle fiber. So this is how to do the treatment to the pectoral clavicular fibers and pectoral other fibers, external fibers of the pectoralis major. So this, if time permits, I will show. Otherwise, we won't show this for your understanding. So teres major, the another mimicker of the thoracic outlet syndrome. Teres major always refers pain over the posterior deltoid area, over the triceps of long head, occasionally to the posterior forearm. So the patient always complain pain in this area. So this also mimic the thoracic outlet syndrome and mostly we find the trigger point in the groove between the lateral lower edge of the scapula and the axillary fold where we are palpating the teres major. Teres major. So this is the model, okay, and here ask the patient to abduct the arm. So here on the lateral border of the scapula, you have a bulk. So lateral border of the scapula, we have the bulk. So this area is for the teres major area. If you are, the patient is having pain, then we may suggest a teres major tender point or the trigger point. The examination. So with the examination diagram itself, you easily come to know that patient is supine lying position. Along with this, you have to give a traction through the elbow and bring the scapula out of the body and palpate the lateral border of the scapula. So you easily find the tender spot at the teres major or minor or the latissimus dorsum. And this area, if you are going more deeper, then it is subscapular. For the latissimus dorsi, it is a very huge muscle. It starts from T6 to L5 area. T6 to L5 area. Okay, T6 to T12. After that, it is going to attach along the posterior part of the ilium, and this muscle give pain in the arm also or in the back also. So in the anatomy, you might be studied this muscle, the lady between two major, which is attached in the bicipital groove between the teres major and the pectoralis major. This is attached at the bicipital groove. So the patient have pain in the inferior angle of scapula, mid thoracic area, posterior shoulder, and along the medial side of the uh, hand and the forearm. All these areas the patient is having pain, and most of the time the patient is have pain in the lower back area. So these are the referred pain area in latissimus dorsi. They have radiating pain in the medial side. If the patient is having pain in the medial side, one we can expect the patient is having tender spot over the latissimus dorsi. So trigger point we can find at the angle of the scapula or in the middle portion of the thoracodorsal fascia area. So we do release in physiotherapy anterolateral fascial elongation technique use. Uh, and this is the muscle for subscapularis. The all the scapula, the front part of the scapula area, we are having the fibers, and which is attached in the lesser tuberosity of the humerus. It is attached in the lesser tuberosity of the humerus, that will be at the anterior part of the humerus. And if the patient is having subscapularis tender spot, so these three areas they are having here for the clear demonstration. The all the ribs has been cutted here. So if the patient is having subscapularis tender spot, they have a referred pain around the scapula, mostly the posterior aspect of the shoulder. They have pain, and the patient complains carpal tunnel syndrome type pain. Carpal tunnel syndrome type pain. It's not a carpal tunnel pain. But, okay. If the patient complains pain here, then automatically our hand should go and reach the subscapularis muscle. If we are releasing that, the pain will go. So this is the position for a latissimus dorsi MET, the muscle energy technique, to release the latissimus dorsi. We position the patient like this. And generally, we do arm pull in the shoulder to get relieved by this conditions. Arm pull in myofascial release or pectoralis major or minor direct releases we can do. This is pectoralis major muscle play and pectoralis minor muscle transverse friction. And we find the subscapularis at the anterior aspect of the inferior angle of the scapula. Anterior aspect of the inferior angle of the scapula. Then if you want to release the subscapularis, you have to release with the thumb. Otherwise, this is too sensitive area. The patient do all the withdrawal symptoms. So that time you use your Tina reminens. Apply some moisturizer, then you release along the lateral border of the scapula somewhat deep. That is, your pressure should go anterior to the lateral margin of the scapula. So this is how to release the upper intercostal muscles. So in case of the subclavius muscles, we release, or in case the patient is having Scalenus Minimus tender spots, we release this. So in order to provide a very good breathing to the patient. So lower intercostal muscles, we release this. This is helpful for the Latissimus dorsi trigger points also. So this all the exercises we can do. We can teach the diaphragmatic breathing to the patient and the wall push or scapular squeezes, shoulder elevations, shoulder circles, and the stretch of the shoulders we can do. So these are all the some of the treatment parts are some general exercises we can advise to the patient. So that's all about the theory parts. I think you well understand about the condition thoracic outlet syndrome and its mimicking muscles. Particularly, the thoracic outlet syndrome is of three muscles origin. The first of all, the scalenus muscle, scalenus anterior, scalenus posterior, scalenus middle. Okay. Apart from that, we have the mimicking areas like subclavius muscles and the pectoralis muscle, subscapularis muscle, and other two muscles, Teres Major and Latissimus dorsi. So once the patient coming to you and complaining pain in the whole upper leg, so are thinking it should not go. It is a disc problem. The patient, all the patient, they won't come to you with a disc problem. So the patient will have a facial joint problem also, or some other bony anomalies they may have. So you rule out that. After that, as a physio, I go to the muscles. I concentrate on the muscles. So I concentrate on all these 8 muscles and I try to release those 8 muscles and try to bring the improvement. So we have to always differentially diagnose the conditions. Try to do that differential diagnosis in your clinical practices. So my aim of the lecture is how to do a differential diagnosis in this. I think my part I did very well. After this, whenever the patient is coming to you, you also try to locate those trigger points and you have some queries about the conditions. That time also you can ask me questions. Now, if you have any questions, you can ask me. The session is open for question and answers.
Thank you so much, sir, for this wonderful presentation. Actually, it is a nostalgic feeling for me because you took me 8 years back to my classes. Thank you so much.
Thank you.
It is already a vibrant session and always as educational as it was earlier. In the meantime, I have seen that our VC sir, Honorable VC sir, has joined us. Uh, before moving, I would I would request, I would like to actually welcome VC sir, Professor Dr. SP Singh sir. Uh, Sir is a well-known academician and administrator having dynamic and enterprising personality with more than 30 years of
That's good.
experience. in teaching, research, academics, administration in reputed institutions all across the nation. Sir has been associated with the Royal Group from its inception in 2009 and as a founder director of the institution. He further moved to the MET Group of institutions in 2013 and joined as the senior vice president academics and was responsible for functioning of 6 campuses of the MET University.
Oh, good.
He also served as the founder vice chancellor of the MET University Chhattisgarh and for 2 years before joining the Royal Global University in 2016. With the vision and hard work of Professor Singh, the university has been ranked #1 private university of Assam by the education world within a span of just 3 years.
That's good.
The Royal Group is blessed twice to have association of Professor Singh in its journey. While serving his second tenure as the Vice Chancellor of Royal Global University, Professor Singh has completed 20 years of headship of well-known academic institutions of the country. A geologist, MBA, and a law graduate with a PhD in strategic management, Sir is also a baseball player and actively involved in various social and cultural activities since his university days. I welcome you, sir, and request to address the participants with your word of wisdom. The mic is all yours, sir.
Thank you so much, Abhishek, Dr. Abhishek. It was actually, I was in another webinar, what we were just now organizing with the university in Illinois, Michigan. And then I said that I'm with you for half an hour, I'll switch to another webinar. So I'm shuffling from, but it's not physical shuffling, it is digital shuffling nowadays. So I shuffled from WebEx or maybe other platform to Zoom and Zoom to another. So this is another way of life we have learned in the last few months during pandemic time. I'm really grateful to Dr. Arunmozhi, Ranganathan Sahab, Dr. Sahab, thank you so much. Because I was listening to you from last 10, 12 minutes and you was demonstrating also. I was touching my shoulder to find you have a different kind of pain or same kind of pain. And maybe because, at this age, though I'm not very old, but, with the so many stress around, so many working hours are very long, 12, 14 hours every day. This is my 35th year of life when I'm working 12 hours per day. So 35th year of my life, I'm working 12 hours per day. That may be in the office, that may be in the sports ground, or that may be on a discussion forum. So that is my way of life. But this way of life may be a little different for, and that stress your body, that can. So I think I was very, very mesmerized. I don't know. I mean, we know that there's something called shoulder lock shoulder. There's something called, spondylitis. There's something called spinal problem. There's something called numbness in the hand. There's something called spinal cord problem that maybe, and then you have slip disc, then you have. So we have little bit idea about all these issues, but your point of view, the way veins pass through a particular area in your neck and we have some kind of intervention there that leads to pain in your arm, that leads, I have not listened to it, but I know a little bit about this, that how it leads to, some other physical issues. And people at times see that it is a problem with the bones, but it is not problem with the bones. At times it is problem with the muscles or tendons, or maybe as a student of biology, I know these words.
Hello, sir.
This you lost me in between. Am I audible? Yes.
Now you are audible.
Yeah. Now you are.
So, I missed something. So what I'm saying is that I'm repeating it. What I said, that while going to different orthopedic surgeons, I know many of them. Many of my friends are, because I'm from biology side. They are renowned doctors in the country and the world, including United States of America. But somehow this thing has never come to my mind, and we have never discussed about this. So this is a new thing which I've learned today, and I'm really very, very thankful to you and all the participants. I think it's good learning for all of us. I heard, because in the afternoon also there was a professor from MKP College, Dehradun, Dr. Sangeeta. She was there in a webinar from 5 to 6. So
today is Dehradun day.
Dehradun Day. And that was in the National Service Scheme, Government of India for 5 years. So all professors, teachers, readers, they used to come to Lucknow for training in my center at that point of time, 1996 to 2001. So I nearly know at least 5 teachers in every old institution of your Dehradun. Means you talk about MKP College, you talk about the other Pradeep Singh is a geology. I mean, you name any college, I have people there. But then Dehradun is also very close to my heart, and I think DIT, I went there in 2002 to give them approvals when I was at the UP Technical University. So this is and Dehradun is very close to my heart, and I regularly go there. So it was really nice. I heard about your university is also very old university, and you all are doing very well. So I came to know about from my friends. So my best wishes to you, to your Vice Chancellor, to your promoters, and to all the university fraternity. And we would love to see some kind of association in due course of time, whenever the time matures and when we have common beneficial things around us. So thank you so much. And Dr. Ranganathan, it was really nice interacting with you. Thank you. Over to you, Abhishek.
Thank you so much, sir, for your valuable inputs. I am sure the participants were enlightened to hear to you. Moving on, we will go into the question and answer round. And as I am seeing that the question and answer box is getting filled up with a lot of questions. So
yeah, some of the questions I'm seeing here. So swelling of legs and its fingers are also symptom of TOS. See, swelling of fingers are somewhat if the patient is having a vascular obstruction, particularly veins. I can say that a swelling in the fingers may be a symptom of the thoracic outlet syndrome. But the swelling in the legs, it is not the symptom of a thoracic outlet syndrome. It may be sometimes patient have gravitational edema also due to the prolonged sitting or prolonged standing, or mostly the teachers, because I'm also one of the victims swelling in the legs. Okay, every day I have the swelling, and my wife daily she used to scold me because of your profession you are getting. So it may be a gravitational edema or some other reason in the legs, but in the fingers it is not a gravitational edema. It may be a symptom of this venous symptom. Particularly in this condition, you have to palpate the costoclavicular space and release that area. Costoclavicular area. That how to release, I will see that. It is not possible because we are not having a male model here. I will try. Okay. And in case of burn, what happens to that area? Pectoralis minor muscle. In case of burn, it differs according to the degree of burns, how much severe it is. If you have a keloid formation over that area, no problem. So first you release the keloid area and release the fibrous tissue. After that, you are going to release the pectoralis minor muscle. For the pectoralis minor muscle, I show you, I have a female model. Okay. So her name is Karishma. She is also from Assam only. Dibruganj. She is from Dibruganj.
Dibrugarh.
Yeah. Dibrugarh. Yes. Dibrugarh. Okay. So this is a area where we are going to release a pectoralis minor. So I'm finding the axilla from here. My thumb will go towards the coracoid process. Okay, so towards a coracoid process. From here, I show this. From here, I take my index finger towards the coracoid. Fix this. After that, you do a release. So you do the release like this. With the thumb, you move and try to release. But the patient complains more pain. Very severe pain they will complain. So this is for the pectoralis minor area. You release, or in the supine lying also you can do. Make the patient in a comfortable position, supine lying. After that, abduct the arm like this. Then you insert the thumb here at the axilla and take it towards the coracoid process. After that, you release this. It is painful. It is painful. Okay. So for the pectoralis, okay, and for the corococlavicular area, that is, if the patient is having swelling in the arms, then you find the middle portion of the clavicle here, palpate the middle end, medial end. Where from here you come down obliquely down. From here obliquely down. In this area you press. The patient is having pain. Then you really keep your thumb and try to release with some moisturizer. With some moisturizer. But apply deeper pressure, deeper pressure, deeper pressure. So this way you can do. Otherwise, apply some moisturizer. From here you release. A dynamic release you can do along the inferior angle of the clavicle. So I can show you from here along the inferior angle of the clavicle. We go like this you do.
Oh.
In this area. So bit deeper. So this way we can do the subclavius muscle release or upper thoracic release, or the patient is having swelling in the fingers. We can release and see if the swelling which is goes, then we confirm the diagnosis. The subclavius is the culprit. So we diagnose that the patient diagnosis is subclavius tender spot or trigger. Another question, sorry, not audible. This I don't able to answer. Can thoracic outlet syndrome improve on its own? No. Thoracic outlet syndrome, it won't improve in its own because there is no spontaneous evolution for this condition. Other conditions we have. But this is, you have to see where the cause it is. So first treat the cause, then automatically you get the improvement. Another question is, sir, I'm having severe pain on the scapular areas, on back and slightly below. Is this a pain of scapularis? No. Between the scapula, if you have pain medial to the scapula, always check for the cervical disc. Major cervical disc means patient complains pain in this area only. If the patient is complaining pain in the arm, that means it is not a disc problem. It is due to thoracic outlet syndrome. It is coming out of the disc. So if the patient is complaining pain between the scapula, then it is a serious condition, cervical disc problems. Then you have to find which level it is. Does the pain cause low back pain? No. You should not give a connection between this, from this area to that area. We have links of the fascias, but a thoracic outlet syndrome which won't give a low back pain. And Koshik, I think my mother is suffering from the mentioned syndrome because she sometimes suffer immense pain in shoulder and numbness in the finger. That's good. In this pandemic, we are not able to go to an expert also. Can you please show or give us some remedies or exercises? The exercises I shown you before. It is like the breathing exercise you can give, the shoulder, that is scapula squeeze. Scapula squeezes you can do, scapula squeeze. Shoulder elevation you can do, and you can do the rotations and the reverse you can do. So all this thing, and bracing you can do, push, wall push-ups you can do. So this all the exercises we can do. If you want to release, you can see this area, trapezius and the clavicle. So in between this area, so in this area, try to release with some moisturizer. You release हल्के हाथ से इसे रिलीज करते जाइएगा. देखो 5 minutes, about 20 to 25 strokes in a relaxed manner. So automatically they will get some relief they will get. Okay, so this all the thing are the home remedies type we can do. Is there any relation thoracic pain in diabetic patients? In diabetic patients we have a lot of pains. So if the patient really have increased sugar level, then you control that sugar level. Automatically the pain will go. And I have a history of cervical spondylitis. So can you please upload this session? This will be
It's already
cervical
uploaded.
spondylitis. We go with some other sessions, no problem. I'm ready to teach anytime, no problem. Okay, we may have some other session on cervical spondylitis also, because it is one of the very commonest pain, and I go according to a physio. I don't go according to a physician or a surgeon. So by the physiotherapy aspects of work, how we can manage this condition, I can tell you with the practice. Is relating to scapular blade? No. And the scapular blade, I told you, it is the disc. Scapular blade means it is disc. So does a thoracic outlet syndrome show up on MRI? No. No. In MRI, you won't see this. That's the problem. Okay. Even if the patient is having, suppose nowadays we are using laptop and mobile phones, we have a rounded shoulder. Now we also have a pain over this area. In MRI, which is showing that reduced space. So पहले तो वो कोई problem नहीं होगा उनका, वो MRI लेके आने के बाद patient पागल हो जाएंगे, क्या मेरा तो डिस्क स्पेस कम हो गया, स्पेस कम हो गया. So instead of a physical pain, you are simulating that in psychological pain. This MRI. I'm not against MRI studies, but you see the level of the patient, the psychological aspects. We should not create any psychological pain to the patient. So even in the general physician or the orthopedician, orthopedic surgeon, neurologist, everybody they take care that they should not increase the psychological pain. We apply TENS over the shoulder area? Yeah, you can apply. TENS you can apply, no problem, because these are all the counter irritant method. Anything. Otherwise, on the base side, we do like that green color chili, half cut करके उस area में लगाते हैं. वो भी counter irritant. It will work as a counter irritant. So any home remedies it will do. So no problem. Radiculopathy of C5, C6 also have same problem. Then how to check it with the TOS? This you have to go with the differential diagnosis. Always do a differential diagnosis, because every no root having different pains. Okay. So any other questions? I think I answered all the questions.
Yes, sir. Thank you so much, sir, for your valuable inputs. Now, I would like to request our respected Dean of Royal School of Medical and Allied Sciences, Professor Dr. Gitumani Kaur ma'am, to give her concluding remarks. Gitumani ma'am is presently working as the Dean cum Principal of the Royal School of Nursing as well as the Royal School of Medical and Allied Sciences, the Assam Royal Global University. She is the former head of department of the Medical Surgical Nursing of the Regional College of Nursing and has a vast experience of 23 years. She has been given the rank of lieutenant by the Indian Territorial Army for her PhD guideship by the Srimanta Shankardev Health University, with numerous awards under her name, the prominent among which are the Educational Leadership Award, the Women Researcher Award, and RACE 2020 Award for Distinguished Professor. She has also aptly taken a lot of professional roles and responsibilities, which include the Zonal Secretary of Nursing Research Society of India. She is a reviewer and editor of numerous scientific journals, and she has reviewed several books along with a number of publications in her name. Ma'am, I'll be very much thankful if you can please kindly give the concluding remarks. Thank you so much, ma'am. The mic is all yours.
Thank you, Abhishek, for giving a broad introduction to mine. Thank you so much. After all of that, I am a teacher and I am a nurse. So thank you so much. I had a very wonderful evening with Dr. A. Ranganathan, so who has given the topic in a so lively way, along with his beautiful PowerPoint presentations and live demonstration and it was very wonderful. I was mesmerized as well as listening, and I would like to listen to him more. So he has made the evening very beautiful. I hope that all our participants also, they were very much energized with his talk. As we can see, the questions are pouring up. That means they have understood very nicely your talk. Thank you so much, sir. As after the expert giving comment on the topic will be difficult for me, but still I'll try to conclude the topic. So the thoracic outlet syndrome is a condition in which there is compression over the nerve, or it may be arteries, or it may be in the vein at the brachial plexus. And because of that, there will be pain on the neck, and there may be pain on the hand, or there may be numbness. Sometimes maybe there paresthesia. So it depends on the conditions. And if it is neurogenic or the compression in the nerve, there is pain and weakness. And if it is on the vein condition, region is venous, then there will be bluish discoloration, mild, and there will be swelling of the hand, neck, shoulder, and arm. And if it is in the artery, arterial compression, that will lead to pain, coldness, as well as sometimes there may be pulselessness. And if we see the etiology, how it is developing, then there is trauma. It may be repeated movement of the arm, then it may be because of tumor, or it may be because of pregnancy, giving more pressure on the upside, and or it may be because of one extra rib. There may be congenital abnormality. So these are the etiologies. And if we see how much people it is affected, it is 3 to 80 cases per 1,000 population people are getting affected. It is difficult to diagnose because differential diagnosis comes together like frozen shoulder, carpal tunnel syndrome, and package shoulder syndrome. So in the package shoulder syndrome, there will be deep vein thrombosis. So there will be clot formations, and there will be, because of that, there will be pressure on the subclavian area as well as axillary vein. So that leads to same condition. So the treating person or the doctor or the physiotherapist has to rule out whether it is thoracic outlet syndrome or the other symptoms. So that is called differential diagnosis. So treatment, when we go for treatment, so I have gone through a review article where which is done by the Mark R. John, and it is published in the April 2019 in the Springer Journal. They have done a very extensive review on thoracic outlet syndrome, a comprehensive review of pathophysiology, diagnosis, and treatment. They have concluded that 90% of the cases are neurogenic cases. So it is the compression of nerve is more than the other causes. And as there is compression of the nerve, so 98% of the people suffer from paresthesia, and 88% of the people have pain on the neck as well as pain on the arm. And 92% of the people has pain on the trapezius muscles too. And 72% of the patients only have minor chest pain. So when I have gone through the treatment, there is surgical procedures like we can remove the extra rib. If there is extra rib or congenital abnormality, that needs to be removed. And if there is too much compression on the nerve, then surgical decompression has to be done. But it has been suggested that before going to the surgical procedure, it is much better to go for physiotherapy for 4 to 6 months, so that with the help of physiotherapy, it can be cured. So we have to first look for the physical therapy physiological exercises and home remedies like warm compression, as Sir was telling, applying moisturizer. So with all those, there will be cure. So after that 6 months of that, if it is not cured, then only there is suggestion for surgery. So as a conclusion, that I'd like to tell, and especially if we are, as we are dealing with the mostly nowadays, especially the teaching profession people, computer, we are using the computer most with our hands. So always we are giving pressure on our palms. So we should be careful in between. We should be doing shoulder exercises, hand exercises, as Sir was telling. As very well Sir has said, as because of the gravitational force, we are prone to develop the lower leg swellings. So in between, I'd like to advise everybody, though it's not my cup of tea, but still, if everybody in between, after sitting half an hour, if we walk around for 5 minutes at least, that will help. So in between sitting and walking, we should change our style, and we must adopt the healthy styles as much as possible. Thank you so much. Thank you so much to our Honorable Vice Chancellor, sir, for joining with us and giving his valuable time. I'm also thankful to the Dr. Arunmozhi Ranganathan, who has given his extensive work on the topic, as well as his valuable time with us, with making it the session very lively with the live demonstration. Thank you so much, sir. Thanks to all the participants.
Thank you so much, ma'am. It was very enlightening to hear from you, and we look forward to hear to you. To conclude the session, I would like to take the opportunity to thank Dr. A.K. Pansari, sir, Chancellor of Royal Global University, Professor Dr. S.P. Singh, sir, Vice Chancellor of Royal Global University, Dr. Gitumani Kaur, ma'am, Dean of Royal School of Medical and Allied Sciences and Royal School